Hello, I'm Jan Latham.
And I'm Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. James Cleary. Dr. Cleary is the Director of Clinical Research of the Division of Gastrointestinal Oncology, a clinical investigator in the Hale Family Center for Pancreatic Cancer Research at the Dana-Farber Cancer Institute of Harvard Medical School.
In today's presentation, Dr. Cleary discusses the latest diagnostics and therapeutic interventions for cholangiocarcinomas.
Did you know that Dr. Cleary was amongst the first to show the importance of RTK fusions in microsatellite-stable colorectal cancer and characterize mechanisms of resistance? He also evaluated the efficacy of Binimetinib in NRAS mutated cancers and also identified FGFR2 INDELs in cholangiocarcinoma patients.
What an accomplished pioneer in the field of GI oncology.
So let's tune in and learn from this global leader.
So biliary tract cancers is a classification of cancers that includes cholangiocarcinoma and gallbladder. But really, to take a step back and talk about what these cancers are, they really involve the biliary system. So when I mean cholangiocarcinoma, I mean a cancer that grows within the bile duct, either in the liver or outside of the liver. And so when we're talking about cancer that grows in the bile duct inside the liver, we refer to that as an intrahepatic cholangiocarcinoma, whereas when the cancer is growing in the bile duct outside of the liver, we refer to that as a bile duct cancer. These are very aggressive cancers, and patients can get sick rapidly. Because of this, we've really tried to think hard about what are the risk factors that can lead to a cholangiocarcinoma forming. Similar to hepatocellular cancer, which is the most common form of liver cancer, things that cause inflammation in the liver can cause this. So things like viral hepatitis, NASH, fatty liver, that's becoming more and more prevalent in the United States. But also, as you'll learn about in medical school, liver flukes. That liver flukes, this parasite that can live within the bile duct system, can cause chronic inflammation over the years and lead to cancer. So looking at the worldwide incidence of cholangiocarcinoma, in the United States, there's about 10,000 cases a year, and there's about 1.6 cases for every 100,000 patients. But if you look in Southeastern Asia, where cholangiocarcinoma really has the highest incidences, some of the numbers are really impressive. So for example, Thailand has 85 times the incidence that the United States has. And of course, that's because of liver flukes. The one thing I would say, and this is really a theme of this talk, is that we're learning more and more that all cholangiocarcinomas aren't the same. So you can imagine that patients in Thailand who are getting cholangiocarcinoma because of a liver fluke, their cholangiocarcinoma genomically looks a lot different than the cholangiocarcinomas that we see here in the United States, where liver fluke really isn't a significant cause of cholangiocarcinoma. So thinking about how patients come in with cholangiocarcinoma really tells you a lot about what this disease is doing. People typically come in with jaundice, and really where that's coming from is when the cholangiocarcinoma is growing in the bile ducts. Typically the bile duct is like a pipe where the bile can flow through. But if you have a cancer growing there, it could obstruct the bile flowing, and then the bile has nowhere else to go and it just leaks into the blood. And that's why people come in with jaundice. Cholangiocarcinoma patients also can present with typical cancer symptoms like weight loss and fatigue, but also because it starts in the liver, you can get right upper quadrant abdominal pain. But the thing we see way too much of is cholangitis. Again, that's caused by this cancer causing obstruction in the bile duct system, causing jaundice, but also in the body, whenever there's an obstruction, it really increases the chance of getting an infection. And when you get an infection, because the bile can't drain well in the body, you get cholangitis. And that's one of the nastiest infections people can get. And people can get sick and get septic very, very rapidly. So this picture really gives you an idea. This is a picture of a patient with a perihilar cholangiocarcinoma. And you can almost see how the cancer is just really just growing right into the bile ducts, clogging it. And I really just think of it as a plumbing exercise, that the bile ducts want to have free flowing bile, but when the cancer is growing in there, it clogs the pipe, doesn't let the bile flow through, causing jaundice and causing things like infection. So when you're going to take care of cholangiocarcinoma, you're really going to become good friends with the GI doctors in your hospital, because they're the people who can get you out of trouble. So if you look at this picture here, this is a cholangiocarcinoma growing, clogging up the bile duct. And what GI doctors can do is they can go in and put stents to reopen the bile duct so that the bile can start flowing nicely. And that reduces jaundice, actually can normalize the bilirubin in many cases, but also it helps reduce the risk of infection, which is very, very important in this disease, as cholangitis is really, really nasty. So making the diagnosis of cholangiocarcinoma is really challenging. With some cancers, for example, lung cancer, when you do a biopsy, there's a marker that you can see in immunohistochemistry called TTF1. And when you see that, you're thinking, wow, this is a lung cancer. It's pretty specific for lung cancer. Also, for breast cancer, if you see an estrogen receptor, you're really thinking, yeah, this is breast cancer. There's really no great markers like that for cholangiocarcinoma. So it's really a clinical diagnosis. And oftentimes you'll see a CT scan like this, where you'll see a big liver lesion. And then as long as you don't see anywhere else in the body that looks like a primary, you start to get suspicious. The immunohistochemical pattern from the biopsies is typically you'll see markers such as CK7 and CK19 being positive. Some institutions look for something called albumin in situ hybridization, albumin-ish, which is pretty specific for cholangiocarcinoma as well. However, what's very interesting is one of the most frustrating things in oncology is this thing called cancer of unknown primary. And what cancer of unknown primary is where a patient has cancers. Obviously, they have cancer. You do the biopsy, it comes back as cancer, but you can't tell the patient where the cancer is coming from because you're just not sure. So what I've heard is that Jimmy Valvano, the basketball coach who started the V Foundation, had cancer of unknown primary. And really what it is when you see this patient, the cancer's all over their body, you're not sure where it's coming from. And the reason that's really suboptimal is it's hard to treat a cancer if you don't know where it's coming from, because we treat breast cancer differently than we treat prostate cancer, than we treat lung cancer, than we treat bladder cancer. So it's a really frustrating thing. There have been some molecular biology techniques using gene profiling that's helping us try to figure out, just based on the gene expression profile, where a cancer is coming from a biopsy. And every single time a paper comes out using one of those gene expression profiling to try to figure out the origin of the cancer, cholangiocarcinoma was only on top. It's really always the top cancer of unknown primary when you look at those series. And the reason for that, the reason why when you look at series of cancer of unknown primary, that cholangiocarcinoma usually is the top one, it's just such a hard diagnosis to make. So in terms of managing a patient with a cholangiocarcinoma that you catch early, there's certain principles. And one of the things I wanted to say is these principles are true really for all solid tumors. So when I'm taking care of a solid tumor, whether it's a lung cancer, a breast cancer, a colon cancer, the first question I'm asking is, has that cancer metastasized? Because if the cancer is metastasized, so for example, a cholangiocarcinoma that starts in the liver, if it's metastasized to the bones, it's not something we could cure. So the reason that question, that staging is so important, is you really want to know, has the cancer traveled from the primary site? And if it has, it's an incurable cancer. Whereas if it's still in the primary site, you're thinking, wow, I could cure this. But the only way you could cure it is with surgery. So the priority for patients who present with a cholangiocarcinoma that's still in the bile duct and hasn't spread anywhere else is trying to get that patient to surgery. In certain cases, the patient might be too sick to go to surgery, and then you could use powerful radiation called SBRT to treat that patient. But really, surgery is the optimal way to go. However, even with taking the cancer out surgically, even with taking the localized cholangiocarcinoma out surgically, the risk of recurrence is still high. And really what this means is, we've all heard of this, a patient with cholangiocarcinoma or some cancer, some solid tumor, goes to the operating room, the surgeon tells them they got everything because the surgeon believes it. They look, they don't see any other cells, but then a year or so later, the cancer comes back. What happened there? The surgeon was right. With their naked eye, there wasn't any cancer they could see. However, we know that there can be micrometastases. And so what we do to try to reduce the risk of recurrence in many, many different cancers is after the patient goes to the OR, they get chemotherapy. And the idea of the chemotherapy is to eradicate any micrometastases that are left over after the surgeon did their surgery. And in cholangiocarcinoma, what we use is a chemotherapy called capecitabine. I wanted to point out this trial just because for those of you on Twitter, this trial actually did cause some controversy in oncology circles, especially for people who are very interested in evidence-based medicine, because when you looked at the intention to treat analysis, the p-value was 0.09. However, when they looked at the patients on study who were eligible for the trial, so they excluded some patients who weren't eligible for the trial, the p-value went down to 0.02. So technically, this was not a positive study. But the reason the field has adapted it is when you look at this survival difference, a median overall survival of 53 months in the patients who got the adjuvant chemotherapy versus 36 months, it really seems to be a clinically meaningful difference. So up until recently, for patients with metastatic cholangiocarcinoma, so this is patients who present with a liver tumor, cholangiocarcinoma, that's spread to multiple parts of the body, say the lungs, the bone, other parts of the abdomen. This is a cancer we can't cure, but it's still a cancer we can treat. And the goal of treatment is try to make the patients live longer and also hopefully live better with a higher quality of life. So the way we manage that is not surgically, because really by just taking out the liver tumor, we're not doing anything for the patient because the cancer's in the blood and it's just going to keep coming back. So instead of bringing these patients with metastatic cholangiocarcinoma to the OR, we treat them with systemic chemotherapy. And up until recently, the standard of care has been 2 chemotherapies called gemcitabine and cisplatin. And really after that, we really didn't have any treatment options. But throughout this talk, I'm going to talk to you about how we're now starting to get more and more treatment options for our patients. So this is the study that really established that gemcitabine cisplatin is the best treatment for patients with newly diagnosed cholangiocarcinoma. One thing I wanted to point out is this was a really ambitious effort. It's called the ABC02 study, and ABC stands for Advanced Biliary Tract Cancers. And really what's remarkable about this group is these were trials, these were hospitals throughout England, and they needed about 15 hospitals to get this done because it's a rare cancer. So in many ways, the reason this was published in the New England Journal of Medicine is number one, it really established the standard of care for cholangiocarcinoma. But number two, it really required enormous cooperation to get this trial done since it's a rare cancer population. Recently, in the field of cholangiocarcinoma, a study came out showing that perhaps adding immunotherapy to gemcitabine cisplatin can improve outcomes. And this is really hot off the press. This data just came out in January. And really what this did, and this made the field excited, is it took gemcitabine, which is the standard, and it added PD-1 immunotherapy, a drug called doroluvimab, and compared it to gemcitabine cisplatin alone. And when they looked at it, they saw that the gemcitabine cisplatin with the PD-1 immunotherapy was better than patients who just got the gemcitabine cisplatin. But it's modest. And so the field right now is debating how we want to handle this. So when you look at the adding this PD-1 drug to gemcitabine cisplatin, the trial was positive. The p-value is 0.02. So it's a positive study, but it's really a modest benefit, 1.3 months. The other reason that people are concerned is when they looked at the demographics of the study, 52% of the patients were from Asia. And as we spoke about before, a lot of patients from Asia have liver fluke-associated cholangiocarcinoma, and we're wondering how their cholangiocarcinoma might be different than the cholangiocarcinoma we see in this country. So over the next few months, the FDA is going to be thinking about this data and is going to decide whether they want to improve doroluvimab combined with gemcitabine cisplatin. After a patient gets first-line chemotherapy, after a patient gets gemcitabine cisplatin, eventually the chemotherapy stops working. And so when the chemotherapy stops working, you then switch from first-line chemotherapy into second-line chemotherapy. You give them something else since that first-line chemotherapy stopped working. And we've had an enormous difficulty in this field trying to find chemotherapy that works well in the second line. So that same group before, the ABC group, did the ABC06 trial, and they did a study comparing another chemotherapy regimen called FOLFOX compared to best supportive care. And this trial was positive. So this was a step forward. As a matter of fact, it got an oral presentation at ASCO. But it also shows how far we have to go. So while the trial was positive, p-value of 0.03, it's really modest. It's 0.9 months. So it really shows that chemotherapy, it doesn't work as well as we'd like to. I will say for any cholangiocarcinoma experts in the future, in the audience, there is another regimen, 5-FU and liposomal irinotecan, it's very similar to FOLFIRI, that also has shown promise in second line that's come out recently. But really the point remains the same, that second line chemotherapy, after you give that person that first chemotherapy and they'll stay on it for somewhere about 10 months, after that, your options are limited. You could try chemotherapy, but it doesn't really work that well. So we've been looking for other options. And so one of the ways that modern oncology is approaching this problem is we're trying to use precision medicine. And I wanted to take some time to talk about precision medicine. So for the last few decades, what we've been doing, we being the field, is we treat all patients with a disease the same way. So in this graphic, this population over here could be all the cholangiocarcinoma patients. And as I said, we treat these patients with first-line gemcitabine cisplatin. So even though some of these patients might have cholangiocarcinoma that came from liver fluke, and some might not have cholangiocarcinoma that came from liver fluke, and some of the patients might have mutations that are very, very different from each other, we treat them the same way. And what we're learning, what science is teaching us, is that's an oversimplification. That yes, they all have cholangiocarcinoma, but genomically, they're all very different. But that's how we do it with chemotherapy. So when a patient gets diagnosed with cholangiocarcinoma, the way we're still doing it now is we treat all these patients, even though they're genomically different, with the same treatment, gemcitabine cisplatin. We want to move away from that. And so what we want to do is we want to recognize, and in this diagram, they're using color to demonstrate different molecular subgroups. What we want to do is we want to start treating all of the molecular subgroups with the appropriate therapy. So here you can imagine that all the blue patients have a gene A alteration, all of the green patients have a gene B alteration, and all of the brown patients have a gene C alteration. And so really what you want to do is once you can figure out which subgroup a patient separates into, that will tell you the right therapy. So you want to get the patients in subgroup a drug that works for subgroup A, whereas you want to get the patients in subgroup B, a drug that works in subgroup B. And for the rest of the talk, we're going to be talking how we can do that in molecular medicine. And really, as solid tumors go, lung cancer has really been the top of the field in terms of applying molecular medicine. So what lung cancer doctors have done an enormously good job at is when they meet a lung cancer patient, in addition to telling the patient you have lung cancer, they take their tumor out and they sequence the DNA and they look at what alterations are there, because they know that some patients have an ALK translocation, and those patients with an ALK translocation should get an ALK inhibitor, whereas other patients have an EGFR mutation, and those patients with an EGFR mutation should get an EGFR inhibitor. And by doing that, by finding which subgroup of lung cancer the patient has and getting them the appropriate drug, the outcomes in lung cancer have just gotten so much better. I'm a GI oncologist, and the frustrating thing when I look at this lung adenocarcinoma chart is in GI oncology, we've had trouble doing that. But the reason we're excited about cholangiocarcinoma is that's where we're starting to be able to apply molecular medicine. As a matter of fact, many of my friends call cholangiocarcinoma the lung cancer of GI oncology. And to talk about why this is an effort that we did at Dana-Farber, although I'll say that hospitals all over the country have produced similar data. And what we did is we took a series of 335 patients and we sequenced the tumor DNA of each of these patients. So each of these dots, for example, this green dot represents one patient. And then we're able to see how many patients have, say, a KRAS mutation. So out of this series of 335 patients, 24% of patients had a KRAS mutation. But we found something interesting by looking at this, that there's a group, especially in the intrahepatic cholangiocarcinomas, the cholangiocarcinomas that start in the liver, there's a group of cholangiocarcinomas that have an FGFR2 alteration, whereas there's another group of cholangiocarcinomas that have a KRAS mutation, and another one that has an NRAS mutation, and another one that has a BRAF mutation, and there's not a lot of overlap. So that really started telling us that there's different subgroups of cholangiocarcinoma, just like there's different subgroups of lung cancer. And to look at this a different way, we just looked at the genomic alterations that we have drugs for. So when oncologists speak, you might hear them saying actionable alterations. What we mean by that is when we do a sequencing on the tumor DNA and we find a mutation, if we have a drug for that mutation, it's actionable. And so what we found is in patients who have a cholangiocarcinoma that starts in the liver, an intrahepatic cholangiocarcinoma, that we have drugs for about targeted drugs for about 47% of those patients. To give you an example of this, in intrahepatic cholangiocarcinoma, about 18% have an IDH1 mutation, which we have a drug for, and about 11, although other series suggest 15%, about 11 to 15% of intrahepatic cholangiocarcinoma patients have an FGFR2 translocation. So this gets us excited for these intrahepatic cholangiocarcinoma patients that we can start giving targeted therapies to their cancer. One unfortunate side note is that other types of biliary cancer, extrahepatic cholangiocarcinoma and gallbladder cancer, is very different. We actually only rarely find actionable alterations there. So really, when I'm talking about finding actionable alterations, it's really just the cholangiocarcinomas that start in the liver, the intrahepatic cholangiocarcinomas. So one of the most successful targets in cholangiocarcinoma have been FGFR2 translocations. And to talk to you about this, I just wanted to sort of tell you a little bit about FGFR2 biology. So typically, FGFR2 is a monomer, and when it's a monomer, it does not tell cells to grow. However, when you want a cell to grow, and if you put the ligand of FGFR2, FGF, in cells, it causes a dimerization of the FGFR2 protein, causing the MAP kinase pathway to be turned on, causing the cells to grow. What happens in cancer with FGFR2 fusions is that the cancer cells change, and these protein gets a dimerization domain at the bottom, causing the FGFR2 protein to always be as a dimer and to always be on and always signaling the cell to grow. And that's what's stimulating the cancer cells to keep growing out of control. To show this in a different way, I could just show you what happens in these FGFR2 fusions. This is the FGFR2 normal protein, but what happens is the part of the FGFR2 protein that should be normally after this gets chopped off, and instead another protein comes, for example, TAC3, that has a dimerization domain, and that causes these FGFR2 proteins that should be a monomer to dimerize and cause the proteins to signal the cell to grow. So what's been really a triumph in the field of cholangiocarcinoma is that using inhibitors to the FGFR2 protein, inhibitors that bind to this kinase and don't let it work, it's been able to stop the growth of cholangiocarcinoma. So one now FDA-approved FGFR inhibitor called Binimetinib showed this in a trial of 107 patients, and what they saw was a 35% response rate. And just to give you an idea of what this graph is showing, it's called a waterfall plot, and each bar is a patient, and all of the patients on this side of the graph have their tumor smaller. So for example, these last 4 patients had a complete response, had their tumor shrink 100%, whereas this small number over here, all these tumors unfortunately got bigger. But we call this a 35% response rate because 35% of patients on this trial had shrinkage more than 30%, which is very impressive. And when we looked at the median progression-free survival, and what we mean by that is how long did the drug work until the cancer started growing again, it was about 7 months. Much, much better than the second-line FOLFOX we talked about before, which was only 0.9 months. So this targeted therapy is really helping patients. I should say that this targeted therapy, the other advantage is it's a pill. Whereas chemotherapy is really tough in terms of side effects. You get nausea, vomiting, immunosuppression. We'll talk more about the side effects in a second, but this pill is so much better tolerated than chemotherapy. So it works better than chemotherapy, and it's better tolerated than chemotherapy. And this is just another example of another FGFR inhibitor. And the data is the same. Patients can stay on this drug before their cancer getting worse for about 7 months. Very impressive. The toxicities of FGFR inhibitors, again, better than chemotherapy, but it can cause dryness anywhere in your body surface. So dry eyes, dry mouth, dry skin. It can cause your nails to get very painful and discolored. An interesting toxicity is that FGFR inhibitor inhibits FGFR1 to 3. And it turns out that FGFR1 is in the renal tubules. And ordinarily, FGFR1 allows phosphate to be excreted out into the urine. But by blocking FGFR1, it blocks that process, and you don't excrete the phosphate into the urine and causes high phosphorus levels. So the way we treat this, just like dialysis doctors, is we give patients phosphate binders to keep their phosphorus levels low. Now, targeted therapy, as you can tell, we're excited about it. It's been in advance, but with both of those FGFR inhibitors, they only work for about 7 months. And so the question is why? Why does it stop working? And so I'm showing this diagram. This is a diagram of BCR-ABL. It's from leukemia, but we've learned so much from BCR-ABL, and these lessons are applicable to really any cancer that's using targeted therapy. So the way these targeted therapies work is, in this case, the BCR-ABL protein is causing the cell to grow. And the reason it's doing that is the kinase domain is binding to ATP. And so the way that targeted therapies work is they block this kinase domain. So this imatinib is a kinase inhibitor, and they don't let ATP to bind. And when you block the kinase domain, this protein that's stimulating the cancer to grow doesn't work anymore, and the cancer cells die. So this is really what we want. We want to take the protein that should be stimulating growth and then block it, block the ability of ATP to bind, and the cancer cells die. But what happens, and the reason these drugs stop working, there's actually several reasons, but one of the more common is that the pocket where the drug binds can change. You can get a mutation. So for example, this T315I mutation changes this pocket, and then it just becomes a question of geometry. This imatinib no longer fits in this pocket. And since it no longer fits there, it doesn't work anymore. It's like a key. You have a key to your door in your house. If that keyhole changes, the key no longer can go in. And that's exactly what happens with these resistance mutations. The resistance mutations make it hard for the drug to bind. And when the drug can't bind, then ATP is free to go back there, and the cells can start growing because this protein becomes functional again. We've seen this same thing in cholangiocarcinoma. It's very frustrating. So the reason these FGFR inhibitors only work for about 7 months is eventually we start getting these secondary FGFR2 mutations. And these secondary FGFR2 mutations are in the kinase domain and block the FGFR inhibitor from binding. Extremely frustrating. So the question is, can we overcome this resistance? And in a big development in the field, other FGFR inhibitor, it's called an irreversible FGFR inhibitor because it binds to the kinase domain differently, was able to reverse that acquired resistance. And really, this is something that got everybody excited. So a way you can think about it is a patient walks in, gets 7 months out of the first FGFR inhibitor, but then it stops working. But then you're able to give them this second irreversible FGFR inhibitor called TAS-120, and it starts working again. Why would that be? Because the first drug fit this way, but perhaps the second drug is designed that even though there's this mutation, it still can fit into this kinase domain and block the ATP from binding. So really, chemists have really taken over this space, and they've really needed to be very clever about designing drugs that can fit into crevices and stop the ATP from binding. So one of the questions my colleagues here at the Farber asked is, was there any other FGFR2 alterations that can also cause cholangiocarcinomas to grow, and that could also be drugged with FGFR inhibitors? And so as we were sequencing our patients, we started noticing something called an FGFR2 indel. And it happened in the extracellular part of the protein. Really what an indel is it's just removing a portion of the protein. And typically that's an important part of the protein that keeps the protein turned off. So it's almost like the indel's taking the break, the molecular break away from the protein. And when we saw these indels, we wondered whether they might be functional. And when we looked, we saw some very sad congenital syndromes, one called congenital craniocytosis, where babies are born with these skull abnormalities because the sutures don't close enough because they're still growing. And some of these abnormalities, typically it's an FGFR2 point mutation, but some of them were indels. And that really got us suspicious that these indels were important. And so we saw a patient with one of these FGFR2 indels. And similar to the story I told you before, we were able to drug this and it worked. This woman stayed on an FGFR2 inhibitor for 13 months. And then, just like the other data I showed you, she got resistance mutations in the kinase domain, but we put her on that irreversible FGFR inhibitor and she was able to stay on that for 2 years. So basically she got over 3 years of treatment benefit from 2 FGFR inhibitors in series because she had this FGFR2 deletion. And so really when I think about which FGFR2 alterations are targetable in cholangiocarcinoma, I think translocations, and those are the most common ones, they happen 15% of the time. But these FGFR2 indels, which we see 3% of the time, are also targetable. The other target that we've gotten very excited about in cholangiocarcinoma are IDH1 alterations. And just take a step back, for a long time, a goal in oncology has been to understand why cancer cells' metabolism is so different from normal cells. One of the ways we take advantage of the differing metabolism that cancer cells have from normal cells is PET scans. So with a PET scan, what you do is you inject into a patient radioactive glucose. And in normal cells, they don't process the radioactive glucose the same way cancer cells do. Cancer cells are very, very avid for any type of glucose. And the radioactive glucose just lights the cancer up. So really, when you look at a PET scan, you'll see these tumors that just seem to light up just because they so avidly take up radioactive glucose. So we've known for a long time that the metabolism of cancer cells is different from the metabolism of normal cells, but we haven't been able to take advantage of it. One of the ways that that's starting to change is IDH1. So IDH1 is a metabolomic protein that's involved in things like the Krebs cycle. But what happens in cancer cells is really interesting. It really made me think about this for a long time because it was different than the kinase mutations that we talked about before. What mutated IDH1 does is it makes a metabolite that's not normally present in cells. It makes this metabolite called 2-hydroxyglutarate that really you should never see. So we call it an oncometabolite because this byproduct from this enzyme, IDH1, that shouldn't be there is actually toxic to the cells. And so what happens is when you mutate IDH1, you make this toxic metabolite, this oncometabolite, that makes it harder for cells to differentiate. It blocks their ability to differentiate. When you block a cell's differentiation, that's one way to promote cancer. And so we see IDH1 mutations in things like glioblastoma, AML, and cholangiocarcinoma, and targeting IDH1 in leukemia, AML, has been incredibly successful. So we wondered if targeting the 15 to 20% of cholangiocarcinoma patients that have an IDH1 mutation would also be effective. And so there was a trial that many institutions across the United States and actually across the world took part of using a company's called Agios's IDH1 inhibitor. Initially, it was called AG120, it's now known as ivosidenib. And what the investigators noticed from this trial was that there were some patients who got the IDH1 inhibitor who had long-term stable disease. So it really seemed like it was helping some patients. It wasn't helping everyone. There were some patients who didn't stay on the trial very long, but some patients stayed on the trial for a long time. And it got us excited about this drug to the point where there was a randomized study looking at patients with second or third line cholangiocarcinoma who either got ivosidenib or placebo. And the results of this trial showed that ivosidenib is effective. It's modest. I want to start with that. but it does work in some patients. So when we looked at the progression-free survival difference of patients who got ivosidenib or patients who got placebo, the progression-free survival is 1.3 months better. Modest. But what's interesting is when you look at the patients who did well, who had no evidence of progression 12 months out, 10% of them were ivosidenib patients, and no one in the placebo group made it 12 months out. So it just seems like there's this small subpopulation. We wish we could identify it ahead of time, but they can benefit from ivosidenib for a long time. And this is just showing that it also has a survival benefit as well. One of the really great things about ivosidenib is the easiest drug I give. It's a pill. Patients love it. Really minimal side effects. On the label, it talks about some cardiac QTc abnormalities, but I really never see it. Very, very easy drug, and that's why it's really a favorite of patients. We're trying to understand, though, why it doesn't work longer. Again, this question of acquired resistance. So with a colleague of mine, Julie Lossman, we looked at some patients who had long-term benefit from ivosidenib and tried to understand why it stopped working. And what we saw in this patient who was on ivosidenib from 20 months after their diagnosis to 37 months. So basically for a year and a half, this patient benefited from ivosidenib. And then it stopped working. We wondered why. Why did it stop working? And what was really interesting was in the resistant tumors, another IDH mutation showed up. But this time, instead of IDH1, which the drug was to, there was another closely related protein called IDH2. And so what is happening in this patient's cancer cell is the oncometabolite initially was being made by IDH1, but the drug was blocking that. And the cancer is addicted to this oncometabolite, 2-HG. And the way it started getting 2-HG again is it made another protein make the 2-HG, IDH2. So in the future, what we would like to do is have a drug that not only hits IDH1, blocks the 2-HG from IDH1, but have a drug that hits IDH2. And our hypothesis is if we would have had such a drug, that this patient would have been able to continue on this therapy. Similarly, we had another patient who started off with an IDH1 mutation. It was on the IDH1 inhibitor ivosidenib for nearly 2 years before it stopped working. This patient had a different mechanism of resistance. This patient started off with an IDH1 R132C mutation, the common mutation of IDH1, continued having this, but got a second IDH1 mutation, D279. We did molecular modeling on this, and we found that this second mutation makes it hard for the drug to bind. So it really blocked the ability of ivosidenib to bind. And what was extremely interesting is that there's a new drug from Lilly Pharmaceuticals that's an irreversible IDH1 inhibitor. And my colleague, Julie Lossman, looked at this in the lab. And what she saw is that when you look at how well these cholangiocarcinomas in the lab, cells proliferate, grow, when you get that second mutation, the ivosidenib can't stop them from growing anymore. But this new irreversible IDH1 mutation, IDH1 inhibitor could. And similarly, when you look at the production of the oncometabolite, ivosidenib doesn't really block it that well, whereas the new Lilly one does. So similar to what we talked about with the FGFR, we might just start needing to use these drugs in series to block resistance. So I wanted to wrap up here. I really wanted, first of all, to thank all of you for listening and really drive home the point that for decades, our treatment options for cholangiocarcinoma have been limited. But really what's opening up treatment options for our patient is using molecular medicine. So what we're trying to do is sequence the DNA of all of our patients, looking for certain mutations that we could drug. And when we see those opportunities, we can give those patients pills, targeted therapy that is much easier to tolerate than chemotherapy and oftentimes much more effective than chemotherapy. While this is a step forward, we're still having trouble with acquired resistance, so there's still a lot of research going into why these drugs stop working, and hopefully we can come up with smarter strategies in the future to block that acquired resistance. Thank you very much.